Hello, good afternoon, everybody. We've got a lot of folks joining, so we'll be starting here in just a few minutes. Okay, again, thank you everybody for your patience while we're letting some more folks join. If you are a committee member, will you please add your name to the chat so we can capture your attendance?
Welcome, everybody. And Sharon, will you let us know more at a quorum and then we can go ahead and get started?
Yes, I sure will. I don't believe we're quite there yet.
Okay.
Let's maybe give another minute or so.
Good. Oh, I said hi, Mark. Great to have you back on the Mac. Well, welcome, everybody. We're just, it just doesn't it? Anybody wants to start that band, go for it. Let's see. I think we could probably go ahead and get started as members trickle in. And if we have to wait on approving the minutes, we can do so. But I know it's late in the afternoon, early evening, so want to be mindful of everybody's time. So welcome, everybody. My name is Jessie Mandel, and I'm chairing the Medical Care Advisory Committee meeting. And it's great to see you all. We are going to just have a few quick updates, and then we're going to dive into our budget recommendations hearing. And then anybody that would like to continue to stay on the meeting is welcome to do so, or feel free to leave. So with that, let's go ahead and jump right in. Sharon, how are we on the quorum?
I think we're still missing one or two, so
Okay.
I'm trying to give just another 30 seconds or so, but I think we're a little shy if you want to jump to committee member updates.
Okay, sounds great. So at this time, usually we have some time for MCAC committee members to give either some updates, news, ask questions, flag things. Really, it's just sort of an open time, recognizing the experience and expertise that MCAC members bring to this committee and wanting to make sure that there was enough space and time to do so. With that, do any committee members that are here in attendance have any updates or questions or things that they want to flag during this time? Great. Well, if you do, as we're getting started, I know we have a lot on our agenda that we're going to be covering. If there are things that come up, you're also welcome to bring them up at a later time. Sharon, I'm just realizing that I don't know if Luis is here, and I don't know if he got the changed time. I'm just wondering if all members received the memo that we're meeting at 4 instead of 2. So
yeah, he should have. Yes.
Okay.
And are there any committee members on the phone, perhaps? If you are, please unmute yourself so we can count you, because you can also vote via phone. You would just
Hey, this
unmute.
is Gina Tuttle. I'm here.
Great, thanks, Gina. Okay, and with Gina, you're at a quorum. Jesse.
All right.
Great.
Wow.
Can I get a motion? Gina, have you gotten a chance to look at the minutes from 2021? And if so, any changes, edits, or would you like to approve them?
I will go ahead and approve them if that's okay with everyone else.
Are there any motions to second that?
This is Alan. I'll second.
Great. All right, we've got the minutes approved. We've done it. One other thing, just to quickly mention that this is a virtual meeting. We've made the decision as a committee to continue to hold virtual meetings. If you have any questions about that, please feel free to follow up with me or with somebody from with Sharon about our virtual meetings. Great. All right. Last call for any committee member updates, questions, venting. Okay. Terrific. With that, Emma, I'm going to turn it over to you to give an update on the budget process that we're about to dive into, and also just a reminder. Sorry, Emma. One other thing I just want to remind everybody of: this is public meeting. Virtual can be a little bit weird, as we all know, but if you have any questions, feel free to put them in the chat or raise your hand, unmute yourself, however you'd like to. Jump right in. This is really a place for everybody to talk and make comments. So if you have any questions at any point, just feel free to do so. So with that, Emma, I'll turn it over to you.
Okay, thanks, Jesse. And so I know many of you have heard this explanation before, but for those that haven't, or those that may want a refresher, we just want to basically make sure that everyone understands the budget process that we're about to engage in. So the Medical Care Advisory Committee is just that. They are a wonderfully cross-section group of people, as Jesse said, with expertise who are here to advise the Medicaid program. And so how we start our budget process is that we ask anyone who has a budget request related to the Medicaid program to come to the June meeting of the Medical Care Advisory Committee and to present your request and your rationale behind your request. And then the advisory committee members will take all of that information into consideration. We'll obviously be given all of the literature and documents that you've provided. And then during the July meeting, we'll actually prioritize the list of requests that have been presented at this meeting, again, as a advisory list to the division and to the department. I was going to say the Department of Health, but now the Department of Health and Human Services, soon to be, in terms of which items that have been requested that you have prioritized. And then what happens next is the division will take that list. There are maybe other items that we actually have identified that are needs within the program. We will look at all of that and put together our own list of priorities. And I will say that when we actually prioritize our list, we always make it a point of letting decision makers know where these requests fell in terms of the MAC's priority list, because I think that does definitely carry some weight to let decision makers know that this public group has advised that these are the highest priorities. So we'll put together a list. That list is then presented to our department. and as well as requests from all of the other divisions and programs in the Department of Health. This year, we're going to be doing something slightly different because with the consolidation of Departments of Health and Human Services, we've actually been asked to submit one joint budget request for both Health and Human Services as a future single department to the Governor's Office. And so we'll submit our request, now this time a joint request, to the Governor's Office. We'll walk through all of that with the Governor's Office of Planning and Budget. And then things kind of go a little dark for all of us. So as the Governor's Office is looking at not only the priorities from our new department, but all the departments in state government, and sorts through all of that and looks at all the revenue projections and so on and so forth, then sometime mid-December to, I don't know, this past year, it was clear into January, the Governor's Office will release their budget. And whatever items end up in the Governor's budget for the upcoming year, those are the items that state agencies can essentially speak to and support. If the item is not in the Governor's budget, we can provide information on other items, but we can't advocate for them or speak against them. We are just neutral and just provide information. So I would encourage everyone who is presenting today that this is not the only process that you may want to pursue. I know some of you are already working with legislators to pursue some of these requests. Don't assume that just because you have presented it today that this is all that perhaps you need to do. So if you have something that you want to pursue otherwise, it may be wise to pursue it down the legislative track as well. But all of this information will be made public, so you'll know at the end of the meeting in July just exactly how the MAC prioritized the items that are presented today. So I don't know if there's any questions. I think, like I said, many of you are already familiar with this process. Yeah, Alan?
Yeah, just one question about the new information that we received about the American Rescue Plan. How will that impact the budget recommendations? Are you building your budget assuming that those are going, some or all of the plan is going forward, or are you building it assuming that it may not happen and then you'll add to it if it does happen?
We're building it separate from the ARPA funds. And the reason being is because, you know, and when we cover the ARPA funds, we'll talk a bit about this, but I think both legislative leadership and the Governor's Office are always concerned about building, creating expectations that what we might be able to accomplish with the ARPA funds will be long-term. It's short-term temporary funds. If they can find a way of, continuing some of this funding, perhaps they will do that, but there's no guarantee that they'll do it. So at this point, we're not really looking at building it around the ARPA funds, because they are intended to be temporary at this point.
Gotcha. Thank you.
Mm-hmm. Okay, Jesse, unless there are any other questions, I think we can go to the next agenda item.
Yeah, and I will actually, a question for you and maybe for Sharon, if somebody would like to, is not on the agenda but still wants to make a presentation today, can they still do so?
Yeah, we've always, there have always been folks that have not notified us ahead of time. Sharon, do you want to maybe address that? Do you want them to put their names in the chat feature again, or?
Yes, that would be great if they could put their names in the chat feature. But yes, everybody, this is an open public meeting, anybody can speak. So I do have a list of 13 folks who have asked to present. So we will just start from the list and go there and go down. And then at the end, we'll catch anybody who has put their name in the chat, or if they're just on the phone and want to make a comment, we can open it up there. So.
And could I ask too, if you could put your name and maybe just the topic, that would be helpful for us. So if you can put that in the chat, and then then as Sharon said, we can go to folks on the phone at the end to make sure we get everybody.
Great. All right, terrific. Thanks. I think I've been one of those people before that signed up during the meeting, so just want to make sure we're with that. And then committee members, just a reminder, you feel free to ask questions. I mean, we're going to try and keep them short because we do have a long list, but of course, if you have questions during the presentations, feel free to ask them. So terrific. All right, then I think with that, we're probably ready to dive right in.
So first up, we've got Sarah Hodson and Amy Locke, and I have everyone's presentations that has given them to me, so I will drive to save the time, but go ahead and unmute yourselves, and I will also start the timer to try to keep everybody at 5 minutes as well. Thank you.
Great, thank you so much. My name is Amy Locke, and thanks so much to allow us to share our experiences on this important issue. I'm a family physician and chief wellness officer at the University of Utah, and I've worked with patients to prevent and treat diabetes over the last 20 years of my career. And of note, I'm here to speak on this issue as a private citizen on my own behalf. Type 2 diabetes is one of the major health concerns facing Utahns and Americans in terms of disability and death, and a real driver of healthcare costs. Today, we're asking for attention to cover the care that's evidence-based, safe, and successful in preventing such a costly and challenging chronic condition. And in this case, it's not medication, but a class called the National Diabetes Prevention Program, or the NDPP, that is the most effective. And so the NDPP takes people through changes to lifestyle for lasting outcomes, and in doing so, reduces the risk of diabetes, those at risk, by about 58%. And we've included some handouts, but we don't have slides for today. So about 8% of Utahns, adults, have type 2 diabetes, but 1 in 3 have prediabetes in Utah. And so without intervention, many will go on to develop diabetes within the next 5 years. We're already spending about $1.8 billion per year to treat diabetes in the state. And the NDPP costs on average about $500 a person. Each case that we prevent from going from prediabetes to diabetes saves about $8,000 over a 3-year period. Each person who prevents diabetes also dramatically decreases their risk of other diseases in their lifetime, including heart, kidney disease, blindness, stroke, etc. So I'm going to turn over to Sarah.
Thanks, Dr. Locke, and thanks for allowing us some time to present today. I wanted to just tell you a little bit more about the National Diabetes Prevention Program, and there's some on page 2 and 3 of our handout. The National Diabetes Prevention Program is a lifestyle change program, and it's an evidence-based program that shows significant decrease in the likelihood of developing type 2 diabetes for participants. It's a year-long program, and it's focused on lifestyle change, healthier eating, increased physical activity, reduced stress, and also social support of the other people in the class. It's taught by trained lifestyle coaches and can be delivered in person, online, or a combination of both. And curriculum is available in English and Spanish, as well as other languages. The National DPP is important because type 2 diabetes is common, serious, and costly, and prevention is key. And people with prediabetes who take part in the program can significantly reduce their risk, as Dr. Locke mentioned. It's an upstream program, so it focuses on lifestyle changes and group support. And because of the lifestyle changes and screening components of the program, it also decreases the risk of other costly chronic conditions like obesity and heart disease. And overall, those who complete the program have lower healthcare costs and improved health outcomes. National DPP is covered by Medicaid in 7 states and covered in an additional 4 states with waivers or pilots, so 11 total states. And in Utah, is covered by a number of private insurances like Select Health, EMI, Aetna, Regents Blue Cross Blue Shield, also by Medicare and Medicare Advantage, so a number of coverage options. So we're asking for Medicaid coverage of the National Diabetes Prevention Program for 3% of the eligible Medicaid beneficiaries who meet enrollment criteria. And there's some on the first page, Sharon, thanks, of the handout. So this would be approximately 500 people per year who would be eligible. Their fiscal request is for $87,500 annually from the general fund, and this request is eligible for federal match as well. This is a small investment in a program that has been shown to save money and reduce health costs. And extending the program to Medicaid beneficiaries improves health equity and shows that Utah is committed to supporting access to this effective program for all its residents. We wanted to also make sure you were aware that this work has been supported for several years by a statewide coalition. And those logos are on page 3 of our handout. Sorry for the back and forth a little bit here. But I just wanted to acknowledge the number of partners who have been working for a number of years on the National Diabetes Prevention Program in Utah, and I know a number of them are on the call today showing their support for this. So I'm going to turn our last few seconds over to Dr. Locke.
Making lifestyle change is super hard. It's why people don't do it. And so if I think about the people I've known who've been successful, they've been enrolled in programs like this. And thank you so much. Really appreciate your attention today.
Thank you. Are there any committee questions? All right. Well, thank you so much for your presentation. We really appreciate it, and the great handouts that you shared too.
Thanks.
Great. Sharon, do you want to queue up the next presentation? And you can also just move forward too.
Okay. So we've got Don Clayback, and I will get his presentation up. And Don, if you're ready, take it away.
Great, Sharon. Thank you. And appreciate the timer. I think it works for both of us. Well, thank you very much. My name is Don Clayback. I'm Executive Director of NCART, which is the National Coalition for Assistive and Rehab Technology. We're a national organization of providers and manufacturers of what we call complex rehab technology, which includes things like specialized manual wheelchairs, power wheelchairs, seating and positioning systems, and other adaptive equipment like standing devices, bathing assistance devices, gait trainers, all types of equipment that people with high-level disabilities use. We advocate on both a national and state level, and we partner often with the national disability and medical groups to provide education and advocacy around these topics, really trying to help policymakers set the right standards to ensure access to this equipment is protected. We did submit a presentation to the committee, and there's a 2-page letter or executive summary, if you will, as you look at the package that kind of gives an overview. And then we've given a lot of supporting information that we're happy to talk about at a later time, but we're going to try and hit the highlights today so we can cover our main requests. Complex rehab technology is a small subset of durable medical equipment. The people that use it have high-level needs, and the equipment really serves 2 purposes. It helps them increase their independence and function, and it also helps them manage their healthcare needs. From a state perspective, from the healthcare policy perspective, it does a great deal to help prevent medical complications, things like orthopedic deformities or complications, pressure sores. It reduces medical interventions and hospital stays. So it really has 2 benefits. One, for the individual to really help make them as functional and independent as they can. And 2, it helps the healthcare system because it manages healthcare costs and helps reduce those. But for all that to happen, it needs to be available and people need to access it. It's provided through a fairly complex process that involves a clinical team along with the qualified CRT provider. The challenges that the providers have is it's a very demanding business. There's a high service function, a high labor component, and the reimbursement in many cases really just allows minimal, if any, profit. So as a consequence, there's fewer and fewer companies that actually provide this equipment. Our asks that we're wanted to present to the committee really fall under the payment policy area, and they cover 3 specific items. One is right now the state does not reimburse labor for all repairs of certain items. For example, wheelchair tires, casters, casters, wheels, and batteries for power wheelchairs. There is not a labor component that's paid for those items, although all those items are paid for by other insurers. And again, this gets down to covering the costs that a provider incurs to keep that person independent and up and running. We also are asking for, there's 2 miscellaneous codes. We're asking for payments to be based on a manufacturer's list price less 20% versus the current state policy where you pay cost plus 20%. Again, the higher reimbursement would allow better access and allow these companies to remain in business and continue to provide their services. And the final item relates to the payment rates for certain wheelchair components. And the state has adopted the Medicare fee schedule, but within the Medicare fee schedule, there's special pricing for some of these complex rehab items. Right now, the state does not incorporate that, and we're asking the state to add that to the fee schedule. So all 3 things, there's details in terms of the rationale in our presentation, but they all relate to providing better reimbursement for these items so that the limited number of Utah CRT providers are able to, maintain their business and provide timely repair. Because the fact is, when someone's using this type of equipment, if they don't have access to timely service and repairs, they're going to probably end up spending time in their bed or in their house until they get their equipment back up and running and they can engage in life and work and school. So thank you for your time, and happy to answer any questions.
Thank you. Thank you very much.
Okay, if there's no additional questions, we will go to Ashley Svensson for her presentation. So if you are ready, take it away, Ashley.
All right. Can you hear me?
Yes, we can hear you.
Yes.
Okay. Thank you. So my name is Ashley Svensson. I'm a genetic counselor. Ken Linthicum and I are here today on behalf of Myriad Genetics to talk about improving mental health treatment through genetic testing. You may be familiar with Myriad Genetics. It's a Utah-based laboratory in Salt Lake City. So you already know there is a mental health crisis in this country. Things are particularly bad in Utah. In Utah Medicaid, there are about 40,000 enrollees who have depression or anxiety. And as you know, caring for these individuals is very costly. Next slide. So medication selection can create a very frustrating journey for patients. Prescribing guidelines are very broad, and so this is very much a trial and error process. And as we know, with each medication failure, the chance of remission decreases and the chance of suicide increases. Next slide. So one reason that medication selection can be difficult is explained through genetic variability. So we know that we all have genetic variants that determine the way that we metabolize drugs. They can cause us to metabolize them too quickly and we excrete them before they have a chance to do any good, or we can metabolize them too slowly and the chemical compounds build up and cause side effects. This can be tricky because they're complex pathways and there can be multiple genes that are involved in the breakdown of any one medication. Next slide. So GeneSight Psychotropic is a once-in-a-lifetime pharmacogenetic test. It's a proprietary algorithm that analyzes 14 genes to weigh their combined influence on patient response to 61 psychotropic medications. The test report advises prescribing by looking at a patient's genetic profile and then placing medication into one of 3 color-coded bins based on the gene-drug interactions. Medicare does cover GeneSight. It has since 2015, and I refer you to that LCD. Next slide. So for the sake of time, I'm just going to go very quickly through a clinical study and then turn things over to Kim to talk about budget impact. I'd like to focus on the Brown et al. Meta-analysis, which looked at 1,500 patients from 4 prospective trials and compared outcomes between GeneSight guided patients and patients who were treated as usual, so the typical trial and error process. Next slide. So as you can see, patients whose care was guided by GeneSight were found to have significant improvements in all endpoints: remission, response, and symptom improvement. We know from talking to other payers that remission is the most important, and you can see there was a 49% relative improvement in remission for patients whose care was guided by GeneSight. Next slide. So just want to get a little more granular on the next slide, please. So again, on the left, you can see, one more back. You can see that 49% relative improvement for all patients in the GeneSight guided arm. In the middle, you can see that if the patient underwent a medication switch, they had an 83% relative improvement. And if on the right, you can see the true value of GeneSight. So when these patients were switched from a red bin medication, so one that was genetically incongruent, to a genetically congruent or yellow or green bin medication, we saw 150-fold relative improvement in remission. Next slide. So Kim's going to pick things up. I just wanted to let you know that there was we did share 3 cost effectiveness studies, and from the Benitez et al. Study, what this was a claims analysis that compared costs of caring for patients who are seeking psychiatric treatment either with GeneSight guidance or without. This was over a 2-year period. Next slide. And we found a $3,400 cost savings per patient. Obviously, this will vary based on population and policy. Kim?
Thanks so much. Thanks so much, Ashley. So I think depending on how you guys consider the budgetary impact, when we look at about 135,000 adults in the Medicaid program, we then would apply some statistics that about 30% would have depression or anxiety. For the GeneSight test to be applicable, that patient would need to be prescribed a medication from their provider, and the provider would order it. That probably drops us down to about 12,000 patients. And then when we think about the number of patients and physicians that might use the test, you're talking maybe about 2,400 in a 1-year period. We would be requesting that the test be paid at 67% of the current Medicare rate. We've seen some other genetic tests on the lab fee schedule for Utah Medicaid at that rate. And with a miscellaneous code of 81479, we just made some changes to our test, so we do not have a specific CPT code that we bill. The current Medicare rate is $1,568, which would say that the test would be $1,050 for this once-in-a-lifetime service. And we would estimate that would cost $2.4 million. However, when we take into account the Optum claims savings analysis, we would estimate a savings of $5.8 million for a net savings of over $3 million. We're happy to take any questions. The last slide just shows United Healthcare has covered it. Again, I think it depends on the population that the state would be interested in covering. United Healthcare coverage policies for depression and anxiety when a patient has failed on one medication. That typically is because 50% of the time the first medication will work and 50% of the time the first medication will not work. Medicare covers beyond depression and anxiety to include bipolar disorder, ADHD, mood disorders, and other mental health diagnoses. The test works across all of those, and as Ashley mentioned, we have 61 different medications that we provide a clinically actionable result for physicians.
You might have already said this, but is this, sorry if I missed it, is this covered by any other states at this point?
Sure. Within the Ohio fee-for-service program, they are paying us for the test. We have really focused on the federal side and the private payers, and so we are just embarking on our conversations with the state Medicaids at this point. United also has their Medicaid policies on the managed side. So for instance, in Ohio, you only have about 5% of the population that's going through the fee-for-service program, Jesse, and right, it's all, so we're kind of playing this chicken and egg between the state fee-for-service and the managed care. So we've come to kind of the two places where we have laboratory footprints in Ohio and Utah.
Thanks.
Mm-hmm.
All right, thank you so much.
Sure.
Okay, so our next presentation is from Amy Oliver and Mary Susan Spears, and I will get that going if Amy, you'd like to start.
Hi, thank you for having me. So I'm Amy Oliver, and I'm the president and founder of Intermountain PKU and Allied Disorders Association, which is a local patient support group here that I founded back in 2008. And most importantly, I am a mom of 2 children with PKU. So PKU is diagnosed on newborn screening. It's the very first test that was identified through newborn screening, and Utah began screening in the 1960s for it. Children identified with PKU have to immediately start on a low protein diet where they take not only a specially manufactured medical formula, but they also eat specially manufactured foods to be low in protein. And we're here today to talk about those foods. Medicaid does cover the formula for our kids. It's the foods that are not currently covered. And they have the S9435 code, which I understand is currently closed, and we're asking that it be opened to allow reimbursement for these low protein foods for Medicaid PKU patients. So Utah has a state insurance mandate that requires insurance companies to pay for these low protein modified foods. It's been law since 1999. And so we have a great precedent here in Utah of the legislature recognizing the necessity of providing these foods to our children. Obviously, Medicaid isn't subject to regulation by a state mandate, but it is very important from a public policy standpoint that Utah has enacted this law and did so more than 20 years ago. Next slide. So what are low protein modified foods? So just to give you an example, a typical child with PKU can eat only 7 grams of protein a day. So that's the equivalent of a stick of string cheese or 2 tablespoons of peanut butter. So they have to eat foods that are specially modified to be low in protein so that they can get enough calories and nutrition for them every day. They can't eat regular food you buy at the grocery store. And so for those of you who can see me on my screen, I brought with me what we're talking about. I have a bag here of low protein pasta, and this is 0 grams per serving. And this is what we're asking for coverage for. And I also have a similar bag, super loud, of pasta that I got at the grocery store for 99 cents. So the low protein version, we'll get to the cost, it's around $20. This one's 99 cents, but this one is 7 grams of protein, upside down, 7 grams of protein for 1 serving. So this is not something that these kids can eat. And there's lots of medical things I can get into and reasons why this is medically appropriate. And I have this great medical team from Cambric here, but I just want to say as a PKU mom to 2 kids who are 11 and 14, these kids are hungry and they need to eat food. And if they don't have these low protein foods, they have 2 choices. They cannot eat anything, which means they're starving their body, which causes brain damage and other problems, or they eat the wrong food and they eat regular food from the grocery store that's too high in protein, and that also causes brain damage. These kids are going to eat. They're little kids. That's what they need to survive. And so we need to make sure they have the food that's medically appropriate for them so that they can thrive and be healthy. Next slide. So I'll go over these and then turn it over to Mary Susan. So the types of foods here are basically anything you eat that's not a fruit or a vegetable. Meat is out of the question. Legumes are out, fish, those kinds of things. So PKU kids eat fruit and vegetables, and then these specially modified foods.
So hi, I'm
Mary Susan, you want to jump in?
Sure, I'm Mary Susan. I am a clinical dietitian that has worked with metabolic patients for many years. And this is a list of the different disorders that would utilize low protein foods. And as Amy was saying, without the utilization of these products, they cannot meet their calorie needs, and it can lead to consequences of progressive or irreversible neurologic damage, loss of IQ, seizures, failure to thrive, stroke, and even death, depending on the disorder. Next slide. You can see on average, here's a typical person's or child's meals. An average meal that might cost you about $4 a day and would provide 60 grams of protein. For a low protein diet to provide only 6 grams of protein, it would cost about $22 a day. So you can see about $6,000 difference in cost per year. And if you'll skip forward, this just gives you a potential budgetary impact. We have done recent surveys of the inborn error patients in Utah. There's about 170 patients that qualify based on diagnosis. Only about 5 to 10% of these patients are covered by Medicaid, which means about 20 patients would utilize this service, and the estimated budgetary impact would be less than $100,000 annually. Thank you.
Thank you.
Hi, it's Christine. Sorry, I just had a question. I'm going to turn my camera off. It said that's using too much something. But so currently, with those that are covered with a private health insurance, is that something that the private health insurance companies have been paying for, or is this out of pocket for most families?
So in Utah, if your insurance is covered by our state mandate, the insurance is required to cover the low protein foods. There are some families that have insurance plans that are called ERISA plans that are exempt from state law. So those may or may not cover, but there are many patients who receive coverage due to our state mandate.
And I know in previous presentations, they've talked about what other states utilize this code. We know that Illinois, Florida, Arizona already have this code open. However, many of the states fund low protein foods through their newborn screening program. So the fees that are charged for the newborn screening test actually go back to treatment of the disorders that are identified.
And just average monthly cost for those that aren't covered, what's the difference?
So if you can scoot back about 3 slides, that one. So about $500 extra per month for groceries. And
awesome. Thank you.
Okay. And the other unfortunate thing is, say this patient qualifies for WIC, all of the foods that are provided on WIC, except the fruits and vegetables, are too high in protein for these patients to consume.
Just curious, do you know why Medicaid is why, if there's an insurance mandate in place, why Medicaid would not also meet that criteria?
So I think legally speaking, because it's a federal block grant program, the state is not permitted to regulate the benefits provided, is my understanding. I did call the State Insurance Commission just to double check, and they told me that they do not have the authority to regulate Medicaid. But obviously, the state mandate is something that's very persuasive and we would hope would be followed regardless of the legal authority to enforce it.
And so this is Emma. That is correct. The Department of Insurance and the insurance code has no authority over Medicaid. I will say though that I'm not aware that this specific request has been brought to our attention before. So we'll definitely take a look at this. I am curious too how I guess providers of this service, how in other states, how do they get I mean, you don't, typically grocery stores don't bill Medicaid programs, so I'm just wondering
Oh, no.
operationally how that works.
And you can't actually buy any of this at a grocery store.
Okay.
You
Okay.
have to order it from a specialty provider like
Got it.
Canbrook. And they coordinate with our clinic to process those orders and ship them out to the patients. My dream would be to buy this at my grocery store for the same price.
I misunderstood what you were saying. So, okay, that's very helpful. Thank you.
And it is very definitely clinically managed. The physicians and the dietitians are very closely monitoring the utilization of these foods. So it's not just that there's carte blanche to order, all sorts of things.
Oh, of course. Yeah. No, I understand that. So that's very helpful. Thanks.
Thank you so much.
Thank you.
Okay, so next on the agenda, we have Deb Jenkins. So Deb, if you are on, go ahead and take it away.
I'm ready. I am a support service coordinator for the Employment Personal Assistance Services. And hopefully the people on the committee are familiar with this program with the letters that I submitted. But I want to ask today, I want to start by asking you a question. And that question is, have any of you worked for 14 years or even 10 or even 5 and never had a raise? Well, that was my situation until about a year ago. And I finally got to the point where I could not afford to work as a service coordinator for EPAS because I wasn't earning the wages I needed in order to maintain my home and support myself. I started this job in 2008 with 8 clients and left it last year with over 70 clients. I found a job as a support coordinator for DSPD, and at that time I gave up all of my clients except for 15 of them. And the work that I do with EPAS and DSPD is very similar, yet I have to serve 5 EPAS clients for every 1 DSPD client in order to make the wages somewhat even. As service coordinators, we get called at all times of the day, the night, the weekend. Is just the nature of our job. Most people working weekends and holidays and evenings would get an increase in pay, but service coordinators don't. And just one example I have of this situation was I used to have a client who was schizophrenic, and he would call me at 2 o'clock in the morning talking about suicide and whatnot, and I had to take care of him. And there was no extra compensation for that. Another example is we do not get reimbursed for any travel expenses. So I used to cover from the border down to the bottom of Utah County. So like, for example, I had a client in Santa Queen. It would take me at least an hour and a half to get to his house, of course, an hour and a half to get back. And my visit with him would only be maybe an hour. So I would get paid for 1 hour of 4 hours of work. Plus I'd have to pay for my gas and all that kind of stuff too. So that's only one example of why we need a rate increase. Today, there are only 5 service coordinators in the state. When I started, there was at least 10 of us. And only having 5 is becoming a huge problem. 3 of us are totally full. By the way, I did keep 15 of my clients, and I base that solely on they live very close to me, and so my travel really isn't an issue. But the person who took over some of my clients, she ended up quitting 8 months later because of the wages and the workload. She just couldn't handle it. So I've been able to take back a portion of those people, but I only really did it because of COVID right now. I don't have to travel and see those people face to face. I can meet electronically. But when COVID ends, if we're not able to continue meeting virtually, then there's a very good possibility that I may give these clients up, because it's just not financially a good thing to do right now. So the other thing about service coordinators that I wanted to mention to you is we are required to have a bachelor's degree, or at least experience in the field to make up for that. And one thing that used to really frustrate me with my former employer was that they would hire brand new kids right out of high school as direct service or direct care service providers, and they would start their wages at the same wages I was making after working for that company for 14 years. Other things to consider is we do not get paid for our training time, for phone calls to say the state director calls and wants information, educating vocational rehab counselors about the program, talking to former clients or potential clients. There's a myriad of things that we really can't bill for. Unless there is an increase for service coordinators, I see the future of EPASS as pretty bleak. We've already started to witness a trend in people leaving this job. If there are no service coordinators, there isn't going to be any EPASS either. That means 215 people could potentially become unemployed because without the supports they have from their personal assistants, they wouldn't be able to work. I would think that that would cause a much bigger financial impact, paying for more benefits such as food stamps, housing assistance, mental health assistance, because of depression, feelings of worthlessness, isolation, those kinds of things. The present cost of service coordination on average is $46.56 per person per month. That's roughly $10,000 a month. As service coordinators, we're asking the state to consider doubling our rate to bring us up to par with similar coordinating jobs. I hope you will consider that an extra $10,000 a month to serve these 215 disabled workers throughout the state is a great investment. Let's keep these people working on other more expensive state benefits and give the opportunity for more people to take advantage of this great opportunity. Are there any questions I can answer for anyone? Okay,
Thank you. Thanks so much for this presentation.
The next presenter will talk a little bit more specifically on comparing the EPASS rate with other similar coordinator rates. So, okay, thank you.
Thank you.
Thanks, Deb. And so that presenter is Mary Ann Neff. And so I will get your slides up here or your information. So go ahead and take it away, Mary.
All right. Can you hear me okay?
Yes, we can.
Okay, good. Thank you. Hi, my name is Mary Ann Neff, and I own a small business called Northern Utah Case Management, and I provide private contracts through Medicaid throughout the state of Utah for support coordination and for EPASS. I have worked in this industry for 22 years, both as a private contractor and through the state of Utah. And that is included with disability services and foster care services. So I have a pretty broad understanding of the rates and how the services are implemented. So EPASS is a service that I came into a year ago because of an employee that reached out to me and wanted to come work for me. And I agreed to open the contract. And in doing so, I've learned quite a bit about the pay structure of this program and how it relates to other services within Medicaid. And before I go into this, I do want to point out that we cannot be represented through the legislature at this time because we do not have an association that we are attached to. We have to be large enough to have representation, and we're not that big with only 5 employees in the state. So it is necessary for us to come to this committee to advocate for this rate increase So I wanted to offer a very pragmatic comparison to the rates in the state of Utah. And so you'll see on this first page, I've written it out, some of the comparables within the state. So EPAS, we're seeing around $14 to $16 an hour for the case manager. That excludes benefits, mileage, and their driving time, as Deb had pointed out. And I have actually had employees approach me for a job and I cannot pay them what they need to sustain a livable wage, and have turned them down for this program. Comparably, through DSPD, there are waiver services. The first one that I have listed is supported living. And supported living is a program that provides one-on-one support for the individual with a disability with staff. These staff do not need a degree to be able to work. There's no specialized training. We also have supported employment, which is on the DSPD waiver. Again, one-on-one staff with an individual in a community setting to help them maintain their employment. And then we have comparably an EPAS personal assistant, which is the staff that come in and work with individuals on the EPAS program in their home to be able to have skills, to be able to maintain independent living so that they can maintain their jobs. All of these careers are on average $13 an hour, upwards of $16 depending on the model that is used. So you can see that there is a tremendous discrepancy between EPAS and these programs, in that EPAS is requiring a degree. Further, there's support coordination, which is very comparable to EPAS in that we're overseeing that there's a plan and there's a service, and that we're seeing the follow through of that service. If a state manager, or if somebody worked for the state as a case manager through the Department of Human Services, that average wage is going to be just over $34 an hour with all of the benefits included. That's going to exclude transportation, the overhead of the building, office equipment, all of that. Whereas privatization runs higher at about $61.91 per hour, or I'm sorry, per month per case. I'm sorry, let me back up. They bill it on an hourly or a monthly basis, and that wage is going up in July. It averages about $61 per month. There's a cap to about the amount of hours that are worked per case. And that is substantially higher than the EPAS rate. There's also the New Choices waiver, which is a comparable private contract waiver. And that one runs at $18.11 per quarter hour. So if you go below on the sheet that I've provided, I've outlined a visual for this so that you can see exactly the financial difference in the rate. So the baseline rate for EPAS is running $3.12 an hour lower than a supported living rate. And that's the lowest. It just goes from there. So if you see below, I've mapped out, the blue represents the EPAS rate. So we have supported living, supported employment, and these are services that do not require degrees, and they are paying more than EPAS is. Support coordination and the New Choices waiver are substantially higher. Now, EPAS should not exceed those. It's not a waiver. It does not require as much, but the nature of the work is very comparable. At the bottom, I've outlined the requirements that these jobs have. So specifically, we have EPAS, support coordination, and the New Choices waiver requiring a degree, specialized state training. And you can see the difference of what we have in the pay towards direct care staff. The conclusion that I just wanted to make is that the rate of pay for EPAS falls far below multiple other contracts that exist within Medicaid. And I understand that when you attach a waiver on it, you cannot have the pay comparable because the state is paying 1/3 of that cost. On the flip side, as a contractor, I cannot hire staff and expect them to be maintained when my comps are running 2/3 higher than what we are providing through this service. And I will point out that I am a sister to a person that has a disability that has received services through DSPD. And I can attest that these services work. They're very impactful. They're very important to the lives of the individual and to the lives of these families. And every person that is on EPAS, that family would attest that this is keeping them often in the home or in their own home. It's preventing institutionalization, is giving them an opportunity to work, and is giving them the means to be successful in their lives. But I'm very concerned that if EPAS does not run comparable to other rates, that it is going to continue to fall apart. And like Deb had pointed out, if virtual visits cannot be maintained, it's not financially feasible to be sending somebody on the road for 4 hours and only getting 1 hour for compensation for the rate of pay. So the 3 points that I just wanted to end on is that the wages need to be higher than direct care staff. That's just very blatant. It's as blunt as I can get. They cannot be the same as somebody that has no degree and no experience in disabilities and expect this program to run consistent to it. Second of all, it needs to be comparable to other case management jobs. And then the third is that it needs to reflect inflationary cost and the cost of living adjustments that are accommodated through other service industries. So are there any questions?
Thank you so much.
Okay, and so next up we've got Riley, I hope I said that right, and Abigail Merrill. So Riley, if you are ready, I will pull up your slides and you can start your presentation. Thank you.
Thanks, Sharon. Can you hear me? Everybody got me pretty well? Awesome. Okay, I'm seeing a thumbs up. So I'm so excited, you guys, to be with you. Abby and I have been prepping for something this big for so long. We are a two-person show right now that represents, we just recently started Care for Utah's Rare. We are rare disease and medically complex advocates. We're pretty professional at it, as the two of us both have severely medically complex children. So our goal as Care for Rare in our campaign is to increase the awareness of the tragic reality of what it means to be a medically complex family in the state of Utah right now. And we want to assist in creating and building more legislation that would dramatically increase funding for these families, because our children's lives depend on it. So what I want to talk to you guys about today, the two people behind Care for Rare, like I said, my name is Riley. Sharon, you nailed my last name. That doesn't happen. I usually have to correct with people. But this is just kind of our story. You guys can read over it a little bit later. But we have my husband and I have a 2-month-old son. We rushed him to the emergency room in Provo. Sorry, he's 4 now, but he was 2 months old at the time. And we rushed him to the emergency room for what we were told was just a high fever. What we actually found out after some routine blood work was our 2-month-old was in liver failure, and we were immediately transferred to Primary Children's, where we spent the next 3 months trying to figure out what was going on with our son, and it ended with this devastating diagnosis of an extremely rare genetic disorder that most kids don't live past a year old. So the fact that we have made it as far as we have, when Emmett is turning 4 years old, is a huge milestone for us. But his disorder is the first that they have ever seen in the state of Utah. It is that rare. Abby's family, Sharon, if you don't mind going to that next slide for me. Abby's family has a crazy story as well. In her 2nd trimester of pregnancy, Abby was extremely sick. Her doctors told her that it was normal to be sick, that she didn't need to worry. And at 23 weeks, she was rushed to the emergency room where they found that she was in diabetic ketoacidosis. And at that point, she had developed type 1 diabetes while pregnant. And Noah, her baby, was the one that suffered the most. So when Noah was born, they quickly realized that things were not okay, and he had suffered severe brain damage. His list of diagnoses are just off the charts. Microcephaly, seizures, cortical blindness, so many things that this family deals with. So we're experts. When we say we know, we know. We live through this every day. What we want to present to you guys today is more about the medically complex children's waiver. Right now, the MCCW provides state Medicaid to children that meet the qualifications, and it goes off of the children's income and the children's assets rather than the parent's income and the parent's asset. This is critical, and I'm sure as board members, you guys understand the MCCW. If you don't, I encourage you guys to read over this slide. But what happens is essentially you have a family that says, okay, we need to either choose to live in poverty to stay on state Medicaid and not take care of our family, or we need to make the money that we need to provide for our family and lose all the benefits that their child gets from state Medicaid. So Sharon, if you don't mind hitting the next button for me. These are some statistics as of June 2021. Currently, you guys, right now, there's 500 children enrolled on the MCCW. 25, or give or take a few, more or less of those kids will no longer qualify when the public health emergency ends. The target enrollment at the end of the application periods is 550 kids. Right now, the per member per month cost is about $2,000 in total funds, with $564 of that coming from state general funds. In the last open enrollment that the MCCW had was from May 1st to May 31st of 2019. They received 513 total applications. 140 children were enrolled, my son being one of them. Approximately 100 children in the program period were denied because there's not enough funding. Remaining applications that they received did not prove that the child met program requirements. So those are the numbers that we've received from the state. The thing that needs to be understood about these numbers is they are extremely underwhelming. There are thousands of families in this state, some of them who are my best friends, some of them who are Abby's best friends, that won't even bother applying for the MCCW waiver because the chance of getting put on is so slim. And these parents look at it and say, I would rather not get my hopes up than apply for this waiver. It's a crushing experience. I wish I could explain to you and have you understand, getting your hopes up for something that could totally and dramatically change your financial life and your family's life and your child, and finding out they don't meet the criteria. So on this presentation, I have, Sharon, if you don't mind moving ahead, sorry, I'm bouncing all over the place here. We have a little handout here. I encourage you guys to read through this. The thing I want you to take away from this is right now, Utah ranks last in funding for medically complex families. We are ranked number 50 out of all the other states. Most other states fund about 47 to 58% of their medically complex population. Utah funds 15. That is a devastatingly low number. It makes me emotional to talk about, but these are families that are struggling. These are families that need to live, that are choosing to live in poverty because their child will die without Medicaid. This is how serious this problem is, you guys. I'm so sorry, but it's something that my family has lived through. So I actually, Sharon, if you can just jump, try not to get too emotional here. Okay, but if you can jump through, these are voices from our community. Here's what's happening inside our state, you guys. This is Belle Weingar. Belle actually has CDG, a different subtype. So she's very similar to our son. Belle has been waiting for the MCCW to open enrollment for 2 years. She spent 6 months in the hospital, 4 of those in the PICU at Primary Children's on a ventilator from a cold. And her family is now facing hundreds of thousands of dollars in medical debt. Thomas Potter actually has to live in an institution, South Davis, because family cannot afford to bring him home. It's devastating what these families are going through, okay? Caden, same thing. Caden is extremely cute. Love this kid, but he has an extremely rare disorder, and his mom constantly does not know how they're going to continue to provide for him. They've been waiting for 2 years for the enrollment to open again. The sad thing about the reality of the MCCW in the state of Utah right now is essentially you're waiting for a child to die before open enrollment comes around again. And as medically complex families, to know that there is someone losing a trach, that there is someone losing a child to be put onto the waiver, it's a low blow. It's a double-edged sword. You wish and you pray and you hope so hard for this help to come, but you know that another family has lost their child. Utah families, sorry, I told myself I wasn't going to cry, but it's such a sensitive subject. I'll just finish with this. Utah families are fleeing to other states right now to be provided with the Kate Beckett waiver, to be provided with other state insurance that will keep their child alive. The biggest piece of advice that you find in medical forums online for these families is to not move to this state. I took some screenshots just from today. I have hundreds of these that I keep track of, but this was specifically a post I saw this morning, and it was not the best way to wake up to my day, but a mom in Arizona was looking to move to the state of Utah for disability services, and these are the comments that she got. Do you have to move here? If he's not on SSI, he's going to lose Medicaid. Utah's education system for these disabled children is poorly funded, and these behavioral services at school are few and far between. Do not come. I would recommend staying where you are. Utah has very poor resources compared to other states. I know of people who have left because of the lack of resources. These families are, it's widely known that Utah is not where you want to be. If he qualifies for a waiver, he will likely sit on the wait list for years and years. I wish I could help you understand that these children don't have years. My son's story, this is the last thing I'll share with you and then open it up to questions. My son's story before the waiver looked like this. This is Emmett from 2 months old to about 2.5, 3 years old. We spent 2019 at Primary Children's. We were there for 11 months. We were not able to bring him home. We went through surgeries. The picture on the left always gets me. This whole presentation, let's be real. But this is what our situation was. We had to force my husband to quit his job because Emmett needed to stay on Select Health Medicaid. And what happened is when COVID hit, we did not have the money to travel back and forth from Payson, which is south of Provo, to Primary Children's in Salt Lake. And so my husband, because we couldn't afford to put him in a hotel and the Ronald McDonald House was closed, was forced to sleep in the back of our car so that he could see our son. We had no money. He was not working. And it was just a devastating situation. In August of 2019, Emmett was officially approved for the medically complex children's waiver. And this is what our son's life looks like right now. Emmett has gone on 4 months without a hospital stay. He is able to travel, which is mind-blowing to my husband and I. We recently took him to California where he got to sit on the back of a bike. You know, he's able to stay home long enough to actually have in-home therapy. He's putting weight on his legs. We are able to travel to the aquarium, you know, and he can see animals. He can sit up. He can walk through the zoo. He is a totally different child. Our goal at Care for Rare is to receive more funding for the medically complex children's waiver. If not, the medically complex community in Utah will die off. It is so important to us. And while we don't have numbers of how much funding we need, we know the need, and we are so willing to talk, to sit down and figure out something that works for this community. This is our contact information. I'm so grateful for this time. You guys, please feel free to reach out to Abby or myself.
Thank you so much for sharing your story and for that presentation. Just really appreciate it. I don't have any questions, but I just want to say how much I appreciate you sharing that. Thanks.
Hey, Riley, this is Christine. I just wanted to say thank you. I think that was an awesome job that you did. And I know, I mean, I don't know if a lot of people on the MAC committee understand the difference between DSPD and MCCW. Yeah. But you want to just briefly say that?
Yeah. So this is as far as I understand it. Abby Merrill is on this call with me. Like I said, she's my go-to woman. We're one and the same right now, so maybe she'll have a better answer. But as far as we understand it, DSPD is for intellectual disabilities. That would fall under like the autism spectrum, developmental delays, things that children go through but don't really require a lot of medical intervention. Medically complex children's waiver, some of the requirements that need to be met by families are 3 or more organs have to be involved. You have to see 3 or more specialists. And you have to be able to prove that your child does not developmentally meet age-appropriate milestones such as dressing themselves, feeding themselves, speaking, walking, things like that.
So for a good example, someone on DSPD is someone who is diagnosed with autism, and somebody who is a medically complex child is someone who has a trach, a vent, G-tube, perhaps they have, like my son, he has a neurogenic bladder, and so he has frequent UTIs, so we visit the hospital very often. So these are kids who cannot care for themselves and probably will not ever be able to.
Exactly. I think the biggest difference between MCCW and DSPD is DSPD has a lot of children that are in some ways self-sufficient. They can walk. Some of them can communicate very little sometimes, but they have a way of communicating. Most of the medically complex children are completely and 100% dependent on their caregivers, which are their parents, for any sort of mobility, movement, feeding, anything like that. I hope that Christine, I hope that answered your question. I don't know if that.
Yeah,
is what
no, you're
looking for.
fine. So if these kids that qualify for MCCW normally had an intellectual disability, that's where they would be going over to the DSPD waitlist. And there's no current waitlist for MCCW, correct?
Yes,
Correct.
So
So
there's no
MCCW
wait
was-
list. No, go ahead. You're good.
So MCCW was specifically designed so they would not have a wait list, which is why they have the open period. It was designed so that they wouldn't have to have the administrative costs of having a wait list, which is basically what it's for. They just didn't want to have the administrative costs of maintaining a wait list.
Well, so this is Emma. I think the other piece of this was we didn't want to create another wait list that is similar to the DSPD wait list, which to your point that you made earlier, a lot of people don't get off of that wait list. But I just wanted to mention as well, and thank you so much for, I know we have met with both of you before, and I believe you are working with a legislator also on this particular program, which we don't disagree. We would love to put more kids on the program if we have the funding. So hopefully something positive will come out of this. And I also just wanted to mention that we didn't open enrollment last year because we obviously had, filled all our slots, and also because of COVID. But we are opening enrollment for the MCCW program July 1st. So it'll be July 1st through July 31st. And I was actually going to cover that later in the meeting, but I wasn't sure if we were going to have time. So I don't know, Tanya, if you're on, is there anything more you want to add to that? I know we're disseminating information to a number of organizations and trying to get it, far and wide in terms of the application period that will be open.
Yeah, Emma, just to build on to that, I think that Joseph has also shared that with the MAC members. Sharon has shared that with the MAC members too. So we would encourage you to, it's a question and answer document about the upcoming open enrollment period, a link to the website where people will be able to apply directly through the web, or they can print off a copy. We have them available in English and Spanish, and they can submit those either through that web portal or by fax or by mail. And there's some information on there that if folks have any questions, there's a number they can call. So we just encourage folks on the MAC to go ahead and distribute that information to their contacts as well, because as you said, Emma, we're trying to get the word out far and wide and be able to serve about 75 additional kids with the funding that we currently have. So.
Right, and which obviously doesn't address the problem, but at least it will, we'll hopefully be able to at least provide services for 75 more kids. So just wanted to get that word out.
Incredible. I think just last thing, I put Care for Rare's information on there. Abby and I would love to meet one-on-one with anybody that has questions for us, that would like to talk logistics or numbers. Tanya and Emma have been so helpful in working with us, but we're happy to continue the conversation. We know that this is going to be an uphill battle. There's a lot to talk about, but we're just grateful for the time. Thank you so much.
Thank you.
Thank you so much.
Okay, so next up we have Lisa Thornton.
Hi. It's a good act to follow with Riley and Abigail and their great advocacy. That's so impressive. So the situation that we have is many individuals covered by the DSPD home and community-based services waiver are not receiving the medical care, the care that they need. Sorry, I'm all of a sudden nervous. They're not receiving the care and not using their allocated budgets because of insufficient suitable staff. During the pandemic, parents and caregivers have been given compensation pursuant to Appendix K. And some parents, for example, 10% of waiver individuals over 18 have opted for this compensation. And parents received on average $2,372 a month for providing extraordinary care. The pandemic has shown that parent and guardian caregiver compensation is a feasible and much needed option. So April Blakely reports, I have a daughter with severe intellectual disability and autism, and even with a budget for her respite hours, I cannot find anyone to care for her. So I can work to support our family. The caregiver compensation has helped our family survive financially. We have built a strong coalition over the last few years in support of caregiver compensation for parents and guardians, including the Utah Parent Center, the Legislative Coalition for Disabilities, the Utah Developmental Disabilities Council, Envision Supports, the Autism Council of Utah with Cheryl Smith, and then Senator Harper has an open bill for the 2022 legislative session, and he's having his legislative research staff and policy analyst help. And then we have, most important, many parents seeking another viable avenue of support for the individuals they care for who are currently on the waiver. In 2018, the legislature commissioned a study regarding caregiver compensation regarding spouses, parents, and guardians. And as you probably know, in the legislature, they passed SB 63 allowing spouses to receive caregiver compensation this last year. There's many, many states who have a comparable Medicaid waiver that allow parents and guardians to access compensation that's listed in the handout. This compensation would provide many benefits. Many parents are unable to place their child in residential and day programs as their children are too medically or behaviorally challenging. Many parents would prefer to provide that care and keep their child with them, but they can't afford to leave their regular paying jobs. As a result, many parents are forced to have a sibling or no one to care for their child, or turn them over to a group home if they can. Caregiver compensation for parents would financially allow a parent to stay home, would provide the optimum care for the child, would provide resources directly to the family. This option would keep the traditional family model intact, rather than forcing the individual with disabilities to live segregated from their families and communities. One parent wrote, caregiver compensation is allowing us the option to keep our daughter in our home rather than placing her in a group home. I can stay home with her, provide the intense support she needs, and also help keep our family financially afloat. Diana Sackett, who receives caregiver compensation as a parent, said, honestly, having a choice in who cares for our child is in the most intimate settings, and being able to do so well and not compromising care has been an amazing experience. Our home feels more like our home instead of a workplace with rotating staff coming in and out and working around the rest of our family. Caregiver compensation would save the state funds because paying parents to provide care is much less expensive than paying for residential placement. Many siblings are forced to fill the gap in services, providing care for siblings with severe medical and behavior issues. Sibling studies that's been conducted in Utah are showing clinical significant symptoms of PTSD up to 59% in these siblings. Caregiver compensation could remove the burden of young siblings providing extraordinary care and would provide more parental time and resources to the siblings. One mom wrote, it's odd that we can hire a 16-year-old neighbor and get DSPD funds, but if it's a parent who knows best, they cannot get those funds. My own daughter, Kate, who will be 18 this summer, would run away from school several times a week. When caregiver compensation was offered and I was providing the care, she ran away once in 16 months. Caregiver compensation would, and I deserved that, by the way, that was completely my fault. Caregiver compensation would reduce the burden on the service industry, as many adults are not being picked up for lack of space. These providers cannot serve everyone. One thing that's near to my heart is I'm an attorney and I help with guardianships all the time, and many siblings are being left off legal guardianship because DSPD won't pay a legal guardian. So there's many options to make this work financially, and I'll just take one more minute or 30 seconds. But we can limit the weekly hours for compensation.
Lisa, I think you went on mute.
Sorry, I don't know when I went on mute. There's ways to limit this, maybe a combination of different options where we could make this work. The number of hours could be limited. You could say 25 hours a week. It could be limited to a certain age group. There could be a new waiver that was started that a cap is set on a budget if you're part of that kind of waiver. So we're asking that this committee recommend caregiver compensation for parents and guardians. And that's why we're here. So any questions, I'm happy to answer.
Lisa, you said that that is actively being worked on at a legislative level too. Is that right?
Yes.
Great. That's great.
And it's also obvious that if this becomes, part of the governor's budget, this makes it a lot easier and we get a lot more advocacy help if we can make that happen.
Yeah, absolutely. Thank you so much.
Thank you.
Okay, so next up, Jesse, do you want to go next?
Yeah, I can also wait to the end too. I won't take very long so that other people can hop off. So why don't I just wait until the end?
Okay, so do we have Dave Park? Do you hear? I do not have any handouts, but I know you let me know you wish to speak. So do we have Dave on the phone or on the call? Okay, perhaps not. How about Matt Casperson? Do we have Matt Casperson on the phone? Okay.
Sharon, this is Matt Hansen. I know that Dave Park had indicated in an email exchange with you that he was concerned that he may not be able to make it, but I did hear the presentation earlier about the EPAS, and he had similar concerns, but along the lines of the providers. I represent the director for the Home Care and Hospice Association of Utah. And I am aware, I don't know if I could speak to that just briefly, very briefly for just a moment.
Yeah, sure. Go ahead, Matt.
I appreciate that. Thank you. Dave had just contacted us yesterday, and this is a new concern that just been brought up to us. So I apologize that I'm not very well prepared for it. I had planned just to come and to listen to Dave, but then learned today that he may or may not be able to attend. But similarly to the concerns that were expressed earlier, this is regarding more the caregivers and for the EPAS program. Where Dave indicated that they're just concerned that unless the reimbursement rates are able to keep up with, the other waiver rates and what they're now paying their caregivers and hourly rates, that they're not going to be able to continue to provide services either. And I don't know, because I'm not as familiar with the program, I don't know exactly where he is as far as the reimbursement rates. I imagine that he's reimbursing similarly as he is for their other either private duty or for waiver programs, which tends to be right now, and it's becoming more and more competitive. Many agencies are paying $15, $16 and are able to do so because of other increases that occurred a couple of years ago in traditional Medicaid. But he said there are certain programs that are lagging that he's just not able to keep up with. So I know that that's what he was going to speak to. They do some great work. It's a fantastic program, as has been mentioned, in helping individuals to be able to continue to remain independent at home and continue working. But I don't have much more than that to be able to speak to. So I apologize that he wasn't able to attend.
Matt, we appreciate it. Thank you. And I think if Dave has any documents that he wants to submit, if he could get those, to us quickly so that we can share them with the committee, I think that would be fine.
Excellent. I'll reach out to him to see if he has some figures that he can provide. Thank you, Emma.
Yeah, thanks.
Thank you, Sharon.
Okay. Yes, thank you. Okay, so next we got Andrew Riddle, and let me pull up your presentation.
Thank you, Sharon. My name is Andrew Riggle. I'm the public policy advocate with the Disability Law Center. About 82,000 adults and 34,000 children in Utah experience the most serious mental illness, emotional disturbances. Additionally, around 30,000 of the state's uninsured residents experience serious psychological distress each year. Less than half receive any treatment. The state can no longer conflate suicide prevention and crisis intervention with serious and persistent mental illness. Instead, it must develop a system designed to prevent crisis, hospitalization, or incarceration by delivering the right supports at the right time in the right place. Recovery International found that peer specialists focused on recovery-oriented discharge plans resulted in a significant reduction in the use of restraint and seclusion and hospital readmission rates. Fully integrating them into treatment teams saved Georgia $5,494 per client. We recommend investing in a statewide, standardized, comprehensive certified peer support specialist program, including a Medicaid billable rate covering a living wage and full benefits. Some of the 250 residents choosing to transition out of ICS-ID over the next several years have significant medical needs. Fortunately, they can access needed nursing services in the community. Unfortunately, similarly situated individuals served through or waiting for the community sports waiver don't have access to the same level of care. So all waiver enrollees can fully participate in their community. We'd welcome the MAC prioritizing this $4 million request highly once again. As part of the transition process, ICS-ID are also encouraged to improve quality of life for the remaining residents by reducing bed capacity. The max support for the second half of the $2.5 million in incentives needed to make this financially feasible will be appreciated. To keep individuals out of institutions in the first place, we will be grateful for the max advocacy of at least Social Services Appropriations' original recommendation this year of $1,197,300 to keep hundreds more individuals in their home by offering family behavior, employment, and other supports through DSPD's limited supports waiver. Similarly, the home and community-based settings rule is intended to ensure persons with disabilities live, work, and spend time with people with and without disabilities in the broader community. If the system is going to comply by 2022, DSPD providers need substantially more resources. To that end, it will be extremely helpful if the MAC once again joins the push for a $2 million increase to competitive and integrated employment, as well as a $250,000 increase to transportation rates. Thanks so much for your time, and I'm happy to take any questions.
Thanks, Andrew. Thanks so much. Great to see you.
Okay, so do we have Julie Smith on with us? She was another who I don't have any presentation handouts for, and she was going to try to make it. Okay, so if not, Jesse, we will go back to you.
Great, thanks. Thank you, committee members. My name is Jessie Mandel, and I'm here on behalf of Voices for Utah Children. I will be brief. On behalf of Voices for Utah Children, we would like the Medicaid Medical Care Advisory Committee to prioritize two funding requests that will remove barriers to health coverage for all Utah children. As many of you know, over the years, we've talked about how Utah has one of the highest rates of uninsured children in the nation. We rank 46th out of 50 states. And we also have one of the highest rates of kids that are eligible for Medicaid and CHIP, but not enrolling. In fact, I think we have the highest rate there. When kids don't have health insurance, as many of you know, this has a devastating impact, not just on their short-term health outcomes, but on their long-term health outcomes, and also on their academic success, on their economic outcomes later in life. The family is at greater risk for steep medical bills and poor economic outcomes. So really, insurance is the foundation to so many of the health aspects that we all work so hard on as a committee to advance and help all Utahns be healthy. So specifically, these funding requests are two. One is coverage for children who are otherwise ineligible, except for immigration qualifications. So kids that meet other income guidelines and criteria to enroll, but are not able to enroll in Medicaid or CHIP because of their immigration or citizenship status. We're asking for the committee to prioritize funding so that children can enroll in Medicaid or CHIP just like any other kid in the state. We actually, I think there's this confusion that Medicaid and CHIP is for all kids, and it is, but there are about 10,000 so kids in the state who are shut out of coverage, and not all of these children are eligible for Medicaid and CHIP. And I realize I could have provided the committee with some additional information on that, but a few thousand of these children are eligible for Medicaid and CHIP, but they are shut out of coverage. And so we can't be, as a state, we can't leave kids out. We need to make sure that all kids are able to enroll and not denied coverage. So that would be the first request, is to remove barriers to coverage for income eligible children who are otherwise denied coverage. And the second would be 12-month continuous eligibility. As many of you know, Andrew is here. Someday I will not be here, committee, talking about this, but unfortunately there were some slight gains for this group that was cut back in 2020, and here we are again. Kids do not have a 12-month continuous eligibility. Of course, they have during the pandemic, but once the state of emergency, public health emergency goes away, we will see that churn return. And we need to have 12-month continuous eligibility for kids on Medicaid. It's not just a matter of getting kids in the door, it's also allowing kids the ability to stay covered. And removing continuous eligibility will be a huge step to helping us improve our coverage rates for kids and economic and really emotional, social, stability for a family that doesn't have to worry that a slight bump or a slight change of any kind will result in their child losing coverage. So we ask the committee to please continue to prioritize this important agenda item that will allow all children enrolled in Medicaid to have a guarantee of year-long coverage, just like they do in CHIP, just like they do in the private insurance market. So with that, if there are any questions, and I can follow up with any additional information that people may have as well. Thank you, committee members.
Hey, Jesse, I do have one question. So what are other states doing to help our immigration children have coverage? Is that something that other states already provide, or is that taken care of through different nonprofits or whatever?
No, so there are only about 7 states in the nation that have also that do cover all children through, or allow all income eligible children to enroll in Medicaid and CHIP. It's only about 7 other states are in the same boat we are, which means that kids are just left out of coverage. But those states that have enrolled have seen tremendous success. They haven't seen all kids enrolled, which I think is really important reminder just from a enrollment standpoint. It's a slow ramp up period. A lot of just like any program, we don't see all kids enrolled, but they have seen success, and they've also seen that kind of welcome out effect where, especially coming out of the last 4 years and the chilling effect that we've seen, by covering all kids, it really does signal such a huge just more welcoming atmosphere in the program overall. And so they've seen a lot of otherwise eligible kids that would normally have been eligible under the previous guidelines have still been able to have actually enrolled too.
Okay, so 7 other states do not cover children like we do, right?
No, only 7 states cover all kids. So
only 7 states cover kids.
Yeah.
Okay, sorry,
Yeah.
I just wanted to clarify that.
No, and actually Connecticut might be making some gains as we speak, but only 7 states do cover all kids. Yeah, sorry.
Thank you.
Yeah, thanks, Christine. And I will say that I think about half of states have continuous eligibility. Thanks.
Okay. Thanks, Jesse.
So that is everybody that I have on my list, and I didn't see any in the chat. So if we don't have anyone else to present with 20 minutes or so left, you can proceed with the rest of the agenda or wherever you would like to start. Thank you.
So Jesse, do you have any preferences? Some of these items we can hold until our meeting next month in terms of updates.
Yeah. I don't know if other committee members want to chime in. I would say on the enrollment and expansion discussion, maybe just a quick recap of what we talked about at the CHIP meeting. So for committee members to be aware, and then maybe we just can go into the director's report. I hate to skip over consolidation, but maybe we can see if there's time at the end. Does that sound okay?
Sure, whatever the committee wants, that's great. So okay. Jeff, do you want to take the lead then on the enrollment and expansion?
Sure. So I'll give the short version here as best as I can, just so you're all informed of what's happening or has happened with the CHIP program. So we had worked last year to keep CHIP cases open like we do Medicaid cases today during the public health emergency. And that guidance was changed by CMS in about November of last year. They then worked with our states to change back our emergency state plan amendment that we had signed with them, and have since that time worked to return CHIP to its normal processing, with the exception that we are still not charging any not enrollment fees, but premiums during the course of the year. So with that stated, we worked with DWS to turn the EREP system back on to do what it's supposed to do with the CHIP cases, and that occurred in the month of May for June benefits. On the numbers you're looking at, I'm not showing the numbers today, but if you were to see the numbers, you won't see that drop this month because those are May numbers. Next month, you're going to see a fairly severe decline in the CHIP enrollment. It's approximately 41% of the CHIP cases that have dropped off, 41% of the CHIP children that have dropped off the program. It's 2,892 cases, 6,264 children. The majority of those, and this is a good memo, I think, for Medicaid as well, the majority of those had not completed a review with DWS, and because of that, we don't know if they're eligible or not eligible, but we were unable to continue their cases. We did work with the health plans to try to reach out to them. We did, of course, send notification and that kind of thing to them. The worry, of course, that we have as the state agency is that many of those notices either were unheeded because over the past 14 months, they've been getting a lot of notices and their cases remained open. So that being said, we do hope that many of those will return to us. Likely it will be a slower enrollment process as they may not understand that their benefits are truly closed until they seek medical care. But once that occurs, we do expect to see some of those cases and children coming back to us. So that's the very short version of that. I'm happy to take any questions.
Jeff, can I ask two questions? Just one, so because CHIP doesn't have retroactive coverage, what would happen? Can you just clarify what would happen if a family loses coverage and then, let's say, in August goes to the ER?
Sure. So there is a funny nuance, and this is all of Medicaid and CHIP, but what we allow for is that you have 90 days past the time that your review or your case actually closes. So for cases that closed on May 31st, they have 90 days to come back to us and not have to fill out a full application, but still give us the information to redetermine their benefits and see where they are. The month they come back is important. If they come back in the month of June, for example, we'll return their benefits. It will look like their coverage is seamless. So they'll have coverage for all of the month of June. If in your example, they return in the month of August, we will go back to the first day in August, which is what CHIP allows to occur. There's no retroactive coverage with CHIP, but we do go back to the first of the month. So even if you came in August 31st, it would still go back to August 1st. But it would not, you'd still have a lapse in coverage of the months of June and of July.
Okay, so if you go to the ER like July 31st and then apply the next day, is that it?
Right. It certainly gets a little complicated. There are other things we can do. We can look at a Medicaid spend down for that child, for example, in that month. And then CHIP does allow a 4-day grace period. So depending on where you are at that point, we would certainly look at what we can do for you.
Okay. And then families, I mean, I think the message to get out loud and clear is for families to complete renewals ASAP, but there is a 90-day window starting in May that families have. Once they receive that letter, they have a 90-day window to complete the review.
Yes, and it's really starting in June 1st. So June, July, and August. They have 90 days essentially where they don't have to do a full application with us. We just need to get the information together from them. After that, they can still apply and qualify as they normally would during the course of the year. And then that reminder really is not just for the CHIP kids, it's for the Medicaid kids and adults as well to do those renewals and get those done during this time. When the PHE ends, we have this same issue that will occur in Medicaid. I've been saying this for months, but we want to make sure that we do try and help all those that don't have to get caught up in that to avoid that altogether, where they can renew their case now and be covered for the next 12 months like you normally would.
Thank you. Yeah, I know you've been saying it. Then it happens and we're like, what?
I know.
No, thank you. Thanks so much. All right. Is there anything else? I think, yeah, we can just move forward. Committee members, if you want to spend more time on one or have any questions, or any members of the public, please feel free to jump in too. But with that, I guess we could move on then to the director's report. How does that sound?
Yeah, I think that's fine, Jesse. So this is Emma again, and I think we'll make it a little bit short and sweet and just emphasize. Well, let me talk first of all about the American Rescue Plan Act, what we refer to as the 10% FMAP enhancement. So I know that sounds like a lot of, code talk, but what it means is that the federal government essentially, for the Medicaid program, will increase their amount of money essentially for the state by 10% for services that we provide, home and community-based services that we provide, as well as what we refer to as rehabilitation services in the behavioral health area, which really are all our outpatient behavioral health services, and equivalent services in our school-based skills development program. So this is a very interesting offering that, again, was approved under the American Rescue Plan Act. States had a very limited time to put together plans. I asked Sharon to circulate the plan that we actually submitted to CMS. Essentially, and I'll try to say this briefly, and I'm sure I'll probably miss some things, but states actually had a couple of options. One was to take the funding and try to spend it all between now and the end of March 2022. The other option was to take these funds and basically apply them across a 3-year period. And so working with key legislators, the Speaker of the House, President of the Senate, and then the Governor's Office, the Department of Health and Human Services, or take that whichever way you want, as a combined department or both, put together this plan, which in essence would propose to spend $247 million+ over a 3-year period. And what we've focused on is providing during that 3-year period some additional funding for all providers of these services, which also would include things like home health and personal care, as well as, like I said, all the outpatient behavioral health services, et cetera. And that we would do these additional increases, not as increases to rates, but as supplemental payments that would happen on a quarterly basis that would be paid to providers in addition to the rates that they get right now for the services that they provide. And of course, the purpose of this money is to really help providers to try to continue to overcome the impact of COVID and the struggles that they're having trying to, as we've talked about earlier today, hire a sufficient number of staff, be able to reimburse staff. As we know, we hear every day how difficult it is to hire staff to be able to provide services to our Medicaid members. So a lot of the funds are really focused on these supplemental payments for a period of 3 years. Clearly, what legislative leadership and the governor's office wants us to make clear is that this is temporary. After 3 years, there is no guarantee that the state will be able to step in and continue funding for this level of reimbursement to providers. But at least we will be able to help, hopefully, for this 3-year period. And then the other thing that we looked at were more trying to address a lot of more one-time expenditures. So we've talked about trying to help use some of this money to help support the plan that we have set out in our settlement agreement with the Disability Law Center, which is focused on moving more individuals out of any sort of institutional care and moving them into the community to receive home and community-based services. So using some of the funds to do that, using funds as part of that to also help intermediate care facilities convert their business models so that they're converting to HCBS providers. We are going to hopefully offer an opportunity for providers to submit grant proposals to look at improvements to infrastructure that supports the HCBS program. Caregiver training, again, some other infrastructure grants, looking at perhaps using some of this funding to help secure and retain housing. Obviously, we can't pay for housing itself because that is a big prohibition in the Medicaid program, but to provide those supports that would allow someone to be more successful in terms of securing and retaining housing. One of the items also that we are proposing is that we spend some of the funds to actually do a full-fledged direct workforce shortage study and come up with recommendations that decision makers or legislators can perhaps take action on over a period of time. And then also shoring up, we talked a little bit about family caregiver compensation. I think as was mentioned earlier, that is occurring right now, basically under a special amendment or to our HCBS waivers that is allowing us to utilize funds for that purpose as a result of the pandemic. This would allow us hopefully to continue some of that process, at least until either the state can provide additional funding for that family caregiver compensation. So again, this is we sort of asked for the moon really in this proposal. We're not sure that CMS will approve all of it. We did submit it on the 14th of June, which was the deadline to submit the proposal, and have received an acknowledgement from CMS that it has been received. Now the challenges are going to be trying to figure out how to actually implement all of this. And the other challenge is going to be, we don't know how quickly CMS is going to get back to states to actually engage with us and let us know which pieces of this are acceptable and which pieces are not. So stay tuned. We will continue to provide you an update on this as this whole thing plays out. But that's a very high level overview. I don't know if Nate is still on the line and if he wants to comment, Nate Checkett, or Tanya, if Tanya wants to comment. If Tanya's still on, looks like perhaps she's not on anymore. I know Nate's on, but Nate, I don't know, do you want to add anything to that?
No, I think you've covered the key issues that we're addressing there.
Okay. Any questions from the committee? I'm sure we'll have many more opportunities to talk about this.
Emma, there were a few questions in the chat. Do you want to address those? I think Alan yeah, okay, great.
Oh yeah, thanks, Helen. Let's see. Are there any legislative hoops that we have to jump through? I don't think so. As I said, we've engaged legislative leadership. Technically, based on our Budgetary Procedures Act, the legislature doesn't need to approve Medicaid federal funds, but it's such a big amount of money that we actually engaged the legislature. In fact, this started because Nate and I actually made a presentation to the Executive Appropriations Committee, which started the discussion. So I don't know. I mean, technically they don't have to approve it, but we're certainly going to keep them engaged in the discussion. And then to Matt Hansen's question, we haven't posted it yet, Matt, but I did ask Sharon to send it to the MAC committee members as well as the MAC attendees. So if you didn't get it, we'll send that to you, and we'll get it posted to our website as well.
One thing the MAC may want to consider for a future meeting is that the state does have the ability to amend its request. And if the MAC wanted to review what was submitted and provide the department with feedback, that's something that we would take under consideration. We'll also be seeing if there's any additional feedback from legislators.
Yeah, thanks, Nate. I appreciate you reminding me about that. So actually, yes, we can amend the plan, and it basically we would amend it. We will be required to do a quarterly update to CMS as well as provide a quarterly report on expenditures, and they've indicated that we can amend the plan through this quarterly update that we'll be required to do. So I think, Jesse, with that in mind, and considering it's fairly late in the day, maybe I'll just leave the report at that for now, and then we can catch everyone up on other items unless anyone has any questions about anything else specific.
Can you just give a quick timeline with the waiver and, oh, it's not even on here, but you receive what the timeline is for the waiver, now the renewal process?
Yeah, so we've been, of course, going through the public input process, and we will be submitting our request for renewal before the end of this month. So yeah, we have gone through the entire process, put the waiver together. So that is essentially what we'll be doing, is submitting it to CMS, and then and we're submitting it a year ahead of the expiration, because that is what is required by the federal regulation. And then we will start engaging with CMS, and I'm sure we'll have a lot of discussions back and forth, but that's what we're planning on doing.
Perfect, thank you.
And as soon as we will post also on our website the entire renewal packet as well. So we can go through that in a future meeting, but also point folks to where it will be available on the website.
Great. Okay, and then just one quick question that came in through the chat in the few minutes we have left around Medicaid and vaccination updates. Just a question from Stephanie: are we closing the Medicaid member disparity gap for vaccination rates?
No, I wish I could say we are. We'll address that in one other closing item before we close. We're continuing to work on this issue. Unfortunately, in spite of, and I will say this, so far the department between our one call center, our COVID call center, and our HPRs have made over 31,000 outbound calls to Medicaid members to try to inform them and encourage them, at least through information, to consider vaccination. A number of people have gone ahead and been vaccinated as a result of receiving some of that information, but unfortunately there's still a pretty significant gap between Medicaid members and the rest of the general public. And it was interesting because I was on a call yesterday with other states, and other states are now noting the same issue, that for whatever reason, our Medicaid members just nationally are more hesitant to get vaccinated, or it's not as easy to get vaccinated, or I'm not quite sure what the issue is, but everyone is still struggling with this. So we're continuing to, I mean, we won't give up. We'll continue to make this effort, but there's still a gap. And we could probably fill you in on more of those details in our next month's meeting as well. And then one other thing I wanted to mention. So with all of the consolidation discussions that are occurring, we have had a change again in terms of leadership. And so just to let everyone know that the governor basically has asked Rich Saunders to lead believe they're going to call it, to be the lead innovations officer for the state of Utah. And so Rich will actually work directly out of the governor's office to provide that guidance and leadership to all of state government on innovation and improving state government. Tracy Gruber has actually been identified and asked to lead the new Department of Health and Human Services when the department takes effect July 1 of 2022. And Nate has actually been asked to come back temporarily to the Department of Health and be the acting executive director of the Department of Health until the two departments merge on July 1, 2022. And he will also maintain his role as deputy director for the Department of Human Services. So we're thrilled to have Nate formally back with health for a while. And Nate, I don't know if you want to fill in anything that I missed there, or.
I'm just excited to be back with health. I've told many people this. I expected that when the agencies consolidated, we'd be back together as a team. I didn't expect it would be this soon, but very excited to be back in this new role. It's effective Monday, so we're be starting the ground running, moving on that, and still working through with Human Services on which responsibilities I'll maintain some role with them, but primarily operating as the executive director at Health.
Yeah, thanks, Nate. And as I said, we're thrilled. I feel like Medicaid has a foot in both worlds in Health and Human Services anyhow. So I've kind of joked with Nate and said I feel like nothing really has ever changed for Medicaid because we've been working all along with Nate anyhow. So we're thrilled to have him back in this role. So Jesse, with that, I think we'll save everything else till the next meeting.
That sounds great. And it's great to have you back, Nate. All right. Well, thank you, Emma. Thank you all so much for taking the time to be here today, especially late in the day. So happy almost summer solstice. And thanks, everybody. We'll see you all in July. So thanks again. See y'all soon.
Thank you.
Thanks so much. Bye.
Bye.